We shall now go on to the next session, which is going to be on cataract and corneal refractive surgery. I would have to go away for a couple of hours, but Dr. Srinivas Joshi, can you please come over to moderate along with Anagha and Tamil? I would want the expert panels to sit in the front row and our speakers to go on with the talks. They will take over. It's my loss that I'm going to miss some very good talks in this session. Please ensure it goes
We are really sorry for that, sir. Actually, there were no signages. I'm not sure whether they have put it right. No, they put it now. We also had a handling time actually finding the place. So we'd like to welcome everyone for the session 2 on fellowship program in cataract and glaucoma. We have our expert panel, Dr. Surinder Singh Pandey, Dr. Ramurthy sir, Dr. Sushmita Kaushik ma'am, Dr. Vijaya Lingam, Dr. Ronnie George, Dr. Arup Chakrabarti, Dr. Suhas Aldipurkar, Dr. Gaurav Luthra, Dr. Mohan Rajan, Dr. Ilan Kumaran, Dr. Virendra Agarwal, and Dr. Naresh. So I'd like to now invite our first speaker of the day, Dr. Titial sir. Good morning, sir. Yeah, yes, sir. Yes. All the expert panels are please requested to please come on the first row.
It is a pleasure to be amongst the trainers of our trainers. I think that is what we are going to do. The society is going to be made by people who are going to train the society. And there are some institutions who have done wonderfully well for the country, and some institutions who are coming up to fulfill all the aspirations of a young generation. The talk I have to cover today is looking into a curriculum, how to enhance the quality. I think quality is one word which is so important nowadays because quantity seems to be there in our country. So the quality is missing. So how do we improve the quality? That is the major concern. So my talk not looks into how we have to teach them. My talk captures the idea how to make a good ophthalmologist. That is how to shape the young person so that he gets all these important issues and tackled in a proper manner for a future teacher to be, so that other people follow that teacher. Because that is very important. The teacher is one who can take us through in all these areas. We all know the intensive program has been there for a very long time. And initially, if you look into a beginning of operative practice in our country, right from the early century of 19th, 20th century, it was very unstructured training. Because you see the person, learn from that person, and you have to follow the Guruji right from the morning to evening before the Guru sleeps, and you takes everything from there. Now things have become totally changed. You have a very structured program, and you can see it has to cover the specific area with the timeline. Which is, I think, two important things are there: specificity and the time-bound program, which is so important for nowadays to get our student in a mode where they can qualify, they can get accreditations, and they can join the higher platforms also. So we have to really take the theoretical knowledge to our practical knowledge so that they impart the patient. There are 4 or 5 important things in these areas. One is you have to be very good clinician to pick up things. You have to be a good surgeon. You have to be a good teacher. I consider the students as my teacher because they are going to be teacher for future also. And you have to be a team player. I think, and most importantly, you have to have a very empathic human being. Because if you have these 5 things together, you are a good person. But if you have a good clinical and surgical hand, you become a good surgeon. But everything has to be together to become a teacher. So today we are going to make teachers out of new people who already are teachers and look into those areas which we're going to put into your subject. That is how to be a good clinician. That is going to come with your teaching, maybe through the patients, in your OPDs, your bedside teaching, your operation theatre teaching, Then in the post-op area, which is so important nowadays because sometimes the post-op is much more challenging than the pre-op of your patients. The training, which may be now in the wet lab training areas, hands-on training programs, which is running beautifully across the country. Then you have to be a good counselor. That means your communication has to be perfect. In fact, it has to be much better than your clinical sense. Today, if you look into entertainment, for us it is communication, communication, and communication. If that is well done, then you're going to achieve all these things. Let me say that if you look into Army Center as one of the leading institutions for an ophthalmic residency, one thing which is holding Army Center is the bedside teaching. Because the entire thing is an indoor system. You have a daycare system also. The indoor system was built not only for patient care, it was made for training the young budding people. And discussion through your worker, your assessment in a three-tier system. The resident doctor will work out first, then it will be challenged by your senior resident, the fellow, then it will be challenged in the rounds by the faculty, and in the entire group of faculty, entire group of residents also, where you learn to discuss your case appropriately and come up with a good diagnosis, different diagnosis, and plan your approach to that patient. That is how you have a comprehensive learning. I think bedside teaching is one important area. Apart from the OPD and clinical teaching, and RP Center was one who initiated the subspecialty system in the OPDs. And we had 16 clinics, and those clinics were meant for a proper recording of these cases, which has become EMR now, proper discussion of these cases through the agency, and that is how our agency improved subsequently also. Patient load is always there, but most importantly, respect the patient. Because patients are there, that's why we are there. Otherwise, nothing is so important. Bedside teaching is getting challenged now because more people, more hospitals, more organizations have a daycare system now. You hardly see a patient along with the resident doctors. You hardly see their post-op outcome or treatment outcome in these patients. More importantly, it is one important area, the improving the clinical presentation of resident doctors in front of your teachers. That is how they're going to make a person better, responding to your questions which are thrown to him or her on that particular round where his or her colleagues are standing with her. And that is the challenge we have to put every day in a young person's mind. Why not, how, and that's how they're going to improve subsequently also. So we have this system of bedside teaching which is going to prepare them as a teacher. And it is safe and the environment which is friendly to you because it's your own people are there. And always make sure the student understand the entire discussion. Otherwise, no point having a discussion as such. And challenge the student to come out the better and make sure your entire area is stress-free and focus on the patient care and ultimately the satisfaction. So these are important skills in telecom bedside teaching. Most importantly now it's getting lost because as I said, daycare systems. And more importantly, people have mobiles in their hand, the skills, everything. We have learned all from our seniors because they were all, Google. Now the Google is in your hands, but things have changed so much. But I still think you have to respect your senior person at Google, and he or she can give you important clinical, surgical, patient care aspects much more than a Google, which is not a dynamic thing as far as looking into the emotions of patient as such. Group discussion is an important part, whether we form a group of junior to senior resident doctors, they sit together, they discuss things, and while they have to make a presentation, they have to first make a presentation to a group, then face the audience or the teachers, and that is how they become proficient enough to stand in any conference area and deliver their talks effectively also. Patient learning area is very, very important. Counseling, as I said, is very important. We have to learn the art of counseling, the communication, the patient and patient relatives, and the party. It's very important. Like you have patient yourself, it has to be absolutely understandable. Sometimes language may be a barrier, but we all know eyes is such a subject where you see the person, you know the things, and you can make person understand by making him or her see better. Because if you can see what is happening to patient and make them see better, that's what things are going to improve. Maintenance of record has to be a part of your curriculum, and that has to be perfect, so that at the end of 5 years, 10 years, you have a comprehensive results which can be analyzed subsequently also. The EMR is very, very important And that also is going to be a future research also, which is now going to be artificial intelligence based. Telemedicine, we all know, is a very important area coming up. Every institution has to have a ophthalmology or telemedicine attached to them, because that's going to make you reach every corner of a country and give a proper analysis for your patient, treat them, manage them, and have an effective, you can say, database in a country where you can make a implementation of regulations, maybe for surveys, for analysis, then come out with a proper treatment guideline for these cases. Diabetes is one area which is very, very importantly taken care of. I think subsequent presentation will talk about surgical training. Just to highlight here, these are 8 areas of surgical training which is very important. And most importantly, I can consider any resident doctor who can handle the difficult situation. There I give a certificate in proficient. Because that is important. Normal surgery, people can do it. But somebody can handle the complication, that is the most important thing. If I have to write something, I'm a person, I would write one word. This person is effective, efficient to take care of a complication. And the other person will understand he has gone through the proper training in a particular institution. That should be our motto for making a person understand the lectures, CMEs, go to the wet labs. There are various society meeting wet labs are happening. There are institutions which provide a wet lab in our both sides, giving us simulators, and most importantly, we have to make sure they do a wet lab training, get certification, then do an actual surgery supervised, and these surgeries are recorded and assessed by the preceptor or teacher, corrected, and subsequently you do surgery. Every time you have to do that procedure so that you make sure you've done every day. At my age also, I see all my videos every day and assess myself what I have doing correctly and what I have doing incorrectly, why this mistake happened, why this complication happened, which is a video which can be presentable to the house and which has to be deleted. So that's a very important work for you. So if you do a 5 surgeries, see of surgeries in the evening or night, make sure you learn every day. I think conference attendance is very important. Not only the national conferences, the international conferences are also important. Make sure you get a good fellowship programs. Your surgeries should be assisted. Make sure you go to a person whom you think may be a difficult person, because difficult person will solve your difficult problems also. These are various course-I curriculum we are going to devise, not only for cataract surgery, it is for refractive surgery, corneal surgery, squint surgery, retina surgery, name anything. We have devised the technique in a course-I to do every surgery. You see this is a squint surgery where muscles have been picked up. You can do a splitting, you can do a suturing, you can do a dissection, everything can be done in this case. And this is what we look into. If you have devices where you can have a digitization, where the surgeon can see the polarized pencil to the screen. Same thing can be seen by students also, and you can have multiple people sitting in the OR without disruption, and they have a same feel, same appearance, and improve subsequently. I think this is going to be a future of surgical training in India. In fact, abroad, where every surgical device needs to have this 4K system where you can see the big screen and learn everything in an effective manner. So it's a real-time teaching, which is, I say, a dynamic teaching, which goes not only to the surgeon, to the patient, to the entire team in the OR, and the students sitting in those area. Make sure you build a team, and that should be a part of the curriculum, how to build a team, not only for surgical area, the clinical area, patient care area, investigative area, has to be a team. Single person will not be able to learn anything. It has to be a team for you. So this is what I say, be a team player. So you have resident doctors, nursing staff, faculty, other staff, allied staff, has to ensure they impart the patient care in a team fashion and make sure you achieve everything in a manner. Always be a good teacher. That is hand-holding is important. And it is that you should not be demanding respect to the teacher. The respect should be generated. That is how the things are going to go in future. Nowadays, we understand we have to tackle the large number of students at one go. So sometimes it will be difficult. But a teacher will make sure all the students are looking or listening to he or her. That is very important for us. Good doctor is always there because we train you. But being a good human being is a massive challenge for all of us. So it has to be a combination. I say it's a combo. Good doctor and good human being will make the future of our ophthalmologist. to create an infrastructure. Unless you have an infrastructure, you can't impart the knowledge, skill to your students. The first thing in infrastructure should be well structured curriculum-wise, well established equipment for diagnosis, diagnostics, and areas for a patient care area that includes indoor services, outdoor services, and the OR services. And you need to have a very, very importantly nowadays areas where you can do the, you can say, implantation of devices. Devices can be intraocular. There are so many devices, and that should be clubbed with the procedures. Nowadays, OPD-based procedures are going to be very common in the future. Injections are so common. You do many things. There should be OPD-based procedure. Therefore, a OPD area has to be made in such a manner where you can do these procedures also. And these two things are very important. One is the accreditation of a training facility, which is very, very important. This will be covered subsequently. And certification of trainers. So, who is going to do certification of trainers? We have various, you can say, regulations there. But the best certification would be the response from the students. The free structure should be such a manner. If I take a lecture, there has to be accreditation of that lecture. That means at the end of your lecture, the students should give a marks to your teachers. That is how the teacher is going to improve. Otherwise, it should not be a one-sided discussion. It has to be bilateral discussion. In fact, the students should make a questions after every session, and that should be answered by students and the teacher person. But this is the infrastructure you have to look into nowadays. This I have covered entire accuracy certification. One thing, a research has to be a part of future. Not only looking at clinical research, enhancing thinking, learn the art of evidence-based medicine. Always look for answers for unsolved questions. When, how, where. That is a very important areas. And make sure your thesis is done appropriately. The institution should support the thesis of students because they require support. And the institution where research are given as a you can say extramural grant, they should be also assessed, and there should be an interdisciplinary cooperation in terms of exchange of resident doctors, exchange of research ideas, and make sure whatever you do, whatever you see, make sure it is published. And publication is the only thing which will last for generations. And they know this publication done by this institution and this person. If you don't publish, you are nowhere. So publication is a very important part of our agency training, and make sure you have publication. Unless you have publication, your things will go waste. I have a recording which I done a VHS cassette. I have hundreds of them. They're useless. And now I had a floppy disk and CD. They're going to be useless. And now I am recording all these digital devices. They will also be waste in some year. So therefore, it is important to publish your results in important peer-reviewed journals. Also have a good life apart from the clinical areas also. Dance, play, that makes life better and takes away stress from your body. Physical stress which you have, mental stress has to be taken away. Build the future. Aim for what word I'll say, make sure your students become better than you as a teacher. That's how the things will improve. Thank you for listening.
Thank you, sir. I have a few questions. Sir, we generally feel that refraction and surgical exceptions they are currently undercovered in today's curriculum. What do you feel about it? The knowledge of surgical exceptions among residents, the refraction skills, they are.
But that has to be part of our clinical training. Refraction is a part and parcel of ophthalmic management. As a management, because pre-op, post-op, anytime refraction is a very important case. If you don't do refraction yourself at this stage, then you're going to miss everything. So you can't challenge the work done by your optometrist. So we need to know that area also, that I know the refraction as far as I'm concerned. So I can check what my optometrist has done. And if I see the prescription, I know that it's wrong. But that should be one important area. That should be a part and parcel of this thing. There also it has to be structured. How much refraction you have done, which type of refraction you have done, and that should also be assessed by your prescription. Because refraction one area also is like a surgery. In fact, it's much better than surgery. I keep saying not only to my students, to my optometrists also. They can do a better justice to patient than a surgeon, because ultimately it is their hand. The patient can see better. If I give a near correction, how they have done, make a satisfaction to patient. So this is the important part, and not only optometrists, the resident doctors are missing this art now. Even our optometrists are not being reflected nowadays. They are based on the AR system. So you are right. You look into that aspect also. Second thing is, it is very important that we assess them. Assessment has to be absolutely important, and that should be graded. Maybe every 3 monthly, or when the end of posting, or after 1 year, 2 years, there has to be a set of exams. We know that this person requires some more input from our side also. So assessment is a very important part of curriculum development asset. What are the other part?
Surgical exceptions.
Surgical exceptions, yes, that's a part and parcel of training. We do give those trainings. We have a session on that. Especially now, the country having so many problems sometimes, that always insight to have a good discussion. But that needs to be a part and parcel of that. And it is going to be there. Other thing is, we never had the 2 or 3 important things which have been put into that. One is little bit of biostatistics has to be given to our students so that they know how to do statistics. Second is little bit of idea of a management, because ultimately we all become a manager. So that teaching is never there in our curriculum. There has to be some sessions where we look into that management aspect also. Apart from the communication skill, which are doing our classes from a various group of people, maybe a person who has done MBA, person who is doing hospital management. So those discussions are very important. I would say 2, 3 important which are missing. One is biostats as an important thing. Second is making a person understand how to manage things. In our time, you know that we used to have a camp those days, and camp used to be a good managerial skill development area for a faculty, for residents also, because those 10 days you have to do everything yourself in that remote area and manage the situation like a hospital. So I used to think sometimes my OT management was better than my main hospital, because we should take care of everything one step wise, and get right from the cook to cleaner to work for a clinical area. So that is a managerial skill we have developed that area. But unfortunately, we don't have those camps nowadays. So that skill is gone, and that was the best I've realized in my life: managerial skill and getting a good social relationship. I still remember those students who have gone with me in the camp. I know their family also. That is missing now. That bond is broken. I hope things will change. Thank you.
Thank you, sir. Next, I invite Dr. Saurabh Agrawal to give us talk on clinical training, schedule, and how to best refine it.
Can I make a comment, Sir, Tiyal sir, it was a wonderful talk. I think you covered that there is a 360-degree coverage as far as the training is concerned. But what I want to give all the residents today, which I think we are the golden percent as far as the training is concerned. Today, Indian ophthalmology is the golden era wherein they have got a lot of opportunities for training. They cannot say that I don't have whether you take wet labs or a skill training program or conferences, CV program, YouTube videos, so many things are there. So I think there is a huge opportunity for them. They have to make use of this opportunity and do better and better. So what I find in our thing is when they come for a DNB or for you, for us DNB, and just tell you that when they come for a DNB program, they are all focused on just passing the DNB program. They want to get into a fellowship program, either cornea, glaucoma, or something like that. So the focus is not there. So they want to do the subspecialty fellowship, and then probably they are all focusing on that. I think that mentality has to go, because in 3 years of a DNB or MD, you learn so much, which you can reserve it for posterity.
But Dr. Mohan, just 1 minute. We all understand how much challenging our training has become in the last 10, 15, 20 years. Things have all changed. The MBBS internship good paying in our time, good physician. No longer true, because he's just a student. He's reading books only for MCQs. If I say by a person who has done an internship come to our criteria and put an IB, he may not be able to put an IB also. So that's the deterioration which has happened in the skill wise. Okay. They are preparing their PG from a first year onward. Same thing happening in post graduation. There's so much a challenge, they're not getting enough cases to do surgery. There are few institutions where they get enough surgeries to have. There are enough patients, a variety of patients they have to see. And over that, there's so much a challenge getting a senior NC post in a good institution. They need for that. And they think after they become senior intern or they go for a fellowship, they do there. And then in those fellowships, they train actually. So the entire responsibility, which I told in one of the meetings also, has shifted from the government infrastructure to the private sector now. It is the responsibility of private sector to train these people in a higher specialty areas in a better way. And if you have a courses for fellowships, please make sure they get a better fellowship in all form of training. Because 99% of super specialty training in the private sector. The responsibility has shifted to private sector. We hardly do training. There are only few institutions where do a specialized training, like our PGI or some other institution. That is hardly less than 2%. To 98% the private sector, it is your responsibility to make good curriculum and give a good training in all aspects. So, thank you. Ma'am.
A very nice talk, sir, and I have nothing to add except that I do believe we have to incorporate beyond an ophthalmologist few more things. Like I always tell the student posted with me, two things which are dear to me: discipline. No shortcuts. You have to be on time, you have to stay, even if you don't have work, you do whatever work you want. You have to be available within premises that will take you along. Second thing, grooming. You cannot come to hospital the way you want. I think you are dealing with the public. I always think of that Jane Brown, who used to go after people if they are not well presentable. They are not done. I think it is very important as a physician, we have to be disciplined and presentable to the patient. I just wanted to add
That's a very good point.
Thank you. Okay, move on to the next talk.
Yeah, thank you so much. Actually, I would like to say that Dr. Hitya sir was my HOD, and now and I still had those VHS and CDs that content this session. So I think we all learned from those. And I think, like Madam said, I have nothing more to add after your lecture actually. But still, I would like to just maybe few points might be additional. So I will just run through my presentation, and I think it will be more useful for all of us if we have a more panel discussion, I would say. So, clinical training program and how to refine it. I am Dr. Saurabh Patwadhan. I am director of Nandali Biosciences PG Institute, Sangli, Maharashtra. So this scope actually it includes all the TMPs as well as fellows and short-term trainings. So whenever you think of training, it should have four different parts which should be covered in your training program. So first will be academic, next will be clinical, third will be the surgical, and then the research and presentation. So in academic, basically it means to know about the theory, because what we find is that if the student or any resident or fellow who has come to you for any training and he doesn't know anything about theory, it's very difficult to train them, because you are showing them a certain sign and they cannot see it, because if mind doesn't know, you cannot see. So it's very important to take regular classes. Nowadays we have advantage that we can take a lot of online classes also. We can invite faculty from various institutes and they can take online classes very easily. Weekly and monthly classes schedule should be prepared. So what we generally do is that we have a yearly schedule of lectures which have to be taken, and it should connect have all specialties included in that. And every year we will repeat it, maybe few variations here and there. So what happens, even if there is a first year training or second year training, we make sure that they have touched all the subspecialties in that year. So this includes presentations, lectures, and very useful, like Dr. Munawar sir was previously saying, journal clubs. So cover all topics. Do not miss the basics also, optics and basic sciences. And what we do nowadays is that we ask our resident to teach the optometry student. We have optometry school, so we ask them that you take lectures for them in optics and basics. So that way both things happen. They also learn and they have the art of presenting and teaching others, which is very important. This is one more part which I think has to be done, because what we have seen is that students just prepare at the last minute when the exams are coming up, and all throughout their 2-3 years of post graduation or fellowship, they will not learn, or they will not sit and read about the things. So take written exams and viva every 6 months, so they are always prepared. Our state society had these journal club presentations every month last year. So our students also participated in that. It's a good activities on maybe AIS or state or even district societies to do this, conduct these online courses for various theory as well as journal club, which is very important. Now for clinical and practical experiences, what are the ways you can train? So first, most importantly, initial part of the post-graduation or fellowship is observation. So make sure that your facility has these video cameras attached to your slit lab. Many times what happens, the consultant is seeing the patient. They don't have enough time to show their fellows who are standing behind. But if you have these aids, what happens that the fellow is also continuously learning, and you can discuss, you can ask him questions, what was that, or how to go about these things. As rightly pointed out in the panel discussion, start with refraction postings. I think that is the first thing we ask our students to do. First 3 months, they are actually learning under the head optometrist. So rather than asking them to come and come to the OT and start giving block, we ask them, go to the optometrist, you learn how to do refraction first. And everything is done always under supervision. As they learn, we know that they are much better in clinical. Now they are given the exams, and now they are good. We can give them independent workups and OPDs, and also in these cases the peripheral centers are very useful, where they are all alone, so they can manage confidently. If they have any doubts, they can always do telemedicine, but they have that confidence that I can manage this patient on my own. So apart from that, what we have seen, we are thinking about the sterilization protocol. So many times students pass through institute, but they do not go to any. For example, OCT machine is there. The technicians are doing the OCT and they are just reading the report. They will not do themselves sometimes, but it is must that you should handle all the equipments personally, including B-scan, OCT, A-scan, etc. So that when you go to private practice or you go to job, you know how to deal with devices. Many times, even if optometrists are using these devices, you know when they go wrong. If you have done them yourself. Now, surgical training. Every time, nowadays, if you ask group of PGs or those who want to go for fellowship, the first thing they will ask is how much cutting you get, and obviously, practically, that is what earns you the livelihood. Okay, if you are just an academician or a clinician, you are obviously not going to earn that. So, first important thing when we start the training of a PG or a trainee, we check vision, stereopsis, do refraction of the training, and check the IPD, and also do orthoptic workup. We have seen that there are few trainees, we find that why they are struggling to do surgery. These are very easy steps and they are struggling. And what happens is that they generally then we don't offer them more cases because they are doing more copy and they go back in their surgical training part. What we have found is that many of these students have orthoptic problems, and that's why they are struggling to do surgery. So if you do it at the start, at the beginning, you know how to correct it and how to encourage them to go into surgical training. So first month will be obviously first orientation into different parts of the training center, even the peripheral OPD, and then in the second month we start with the dry lab. So we have certain numbers, like you should do at least 50 switch rings or 100 switch rings or something like that before they are allowed to sit on a microscope and do simpler steps to begin with. So in the first year, we generally start with the SICS steps under supervision. They start with very low risk steps to begin with, and gradually we increase the number of steps. Now, what is important is that give them cases on a regular basis. So you can set a number, say once in 1 week or once in 2 weeks, something like that. I remember in RPC we used to have twice a week OT, and maybe we were given cases once a week or once in 2 weeks. But if you have that constant pace in your training, then generally you get better and better. Okay, so you should have a particular goal for your training program. For example, for our first year training program, what our goal is that the trainee should be able to do an independent, simple SICS case. So that should be your program. So you can achieve it on the go. Also, apart from the cataract surgery, because we know when they go back to private practice, not just the cataract surgery they are going to do. They are going to do a lot of minor surgery And if they have not done it themselves, they have just observed, they are not confident, and many times it's best to incorporate and give steps of simple minor surgeries which are useful in private practice, like pterygium and maybe second lesion removal, etc. Now, most important in surgical training part, what I found is that we must record each and every case what the trainee or the fellow does, because every case is important. The surgeon should learn from that case by analyzing every case. So we encourage them to edit these cases, present in our weekly or weekly meetings, and we also have video discussions on surgeries including 3D. So nowadays, as Dr. Tial sir was saying, that now we have access to 3D surgical videos, which are more useful because it gives more, life-like experience for the trainees. Now, for simple surgery, rule is simple: see one, do one, teach one. That's what we learned during RPC with your mentors or your seniors along with you. And of course, for DNP trainees or fellows, it's very important that they get the opportunity to assist other specialists. Though, for example, you are just training yourself in cataract, but you should, if you are assisted, oculoplasty surgeon or retina surgeon in his surgery, when a case comes in your OPD, at least you know, yeah, these are the procedures that are required for that particular patient. It is immensely useful for the patient if they have a doctor who knows everything about different specialties. Of course, about various institutes have their own norms, but we generally start depending on the skill in the third year, and we start with the 3D teaching course, and then we ask them to watch videos from different resources. Nowadays, there is no, I think, dearth of resources that is available. YouTube is full of videos from which the trainees can learn. So every surgeon or every trainee has this logbook with them where they have to enter everything, the patient details, etc. These are signed by the surgeon, and they are also encouraged to keep their personal handbook where they write down the complications they had, their Oscar score, and what problems they had, where the surgery was taken over by the trainer or anything like that. So this really helps, and we always go for a reverse training technique. I think there are publications on this, where we start with cortex aspiration and eye implantation first, and then we move back to the paper steps, which is really useful because then the hand-eye coordination is better and they learn quite quickly and easily. Okay, so initially there are seniors mentoring the juniors, and senior consultants will always be there around. And don't forget about research, I think already been said. So always have journal clubs. Also, like Tial sir was saying, students should be involved in a lot of other activities around the programs because they are going to be part of the society later. So they should be going for camp hosting, interact with the different patients. They should go for ICOs, social camps, social awareness program, and also in your curriculum, make sure that you train them in soft skills and also ethics in medical practice. So there should be a particular focus on teaching them on soft skills, how to counsel a patient, how to counsel an unhappy patient, what are the tricks in the OPD, what they should understand. Okay, and as I already mentioned and emphasized initially, theory exam every 6 months, practical exam, full recreation of the exam scenario every year. That is what we do for our students. And so thank you. I think I have used my time.
If I can make a small comment.
Yes, yes.
So actually, that's wonderful presentation. Just I want to make a point that usually the fellows or trainees when they come to the hospital, they always come in the mindset that we are here to take care of the patients, or basically they come in the mindset that with that thought they think they are doing a favor to the patient. Actually, it's reverse. By the time they finish their training, actually they should have the mindset that patients are doing a favor to you, because that way they're more compassionate to the patient. They actually see a person to trust the doctor with his eyes it's the biggest blessing you can have. You should be really thankful to them, but they don't realize. They think it's their right to see 10 fellows will be seeing one patient with an indirect forever. And that's not right. You have to give breaks, talk to the patient, your request, is it okay, are you okay, can we see a little more? It's more of a requesting that has to happen from day one. The trainee should realize, and like Tial sir said, that I think everything is there in Google now, everyone's information is already there. So I would say, especially a fellow training program,
you have to impart what is not there in Google. That is your primary objective. What, like in terms of those tricks and tips on how you do your surgeries, be it simple things like shrugging your shoulder, breathing properly, how's your table microscope height. Those are small things which people don't realize, which will affect your surgery in a major way. And also, the other thing is we have to tell them to observe the mentors, how they talk to patients. It's very important. How do you talk? Because 70% of your treatment is done with your talk itself. Then the rest is, even if your surgery is average, it's okay. But your 70% is what actually makes an impact and grows your practice.
Thank you so much. I think before Dr. Deepak just starts his presentation, excellent talk, Dr. Saurabh. Being a training institute, you also have your private practice, right? So, how do you ensure that the patients don't feel that they are guinea pigs? Sometimes we say training institute है तो सब सीखने वाले try करेंगे अपने. So maybe sometimes the word spreads around that you are a training institute, but a government institute where it is already training, we know that. So how do you handle it?
No, we have to have different units for that. So even if it is in the same setup, we can't mix both the patient population. Of course, those who are coming in through the charitable setup, they already know that they are not going to be operated by the expert surgeons. They don't have that option, because in private they obviously know that this particular doctor is going to operate. But like in government hospitals also, we are not going to tell the patient that this particular surgeon will be. It's a team. One of the team members will be operating. So that is the implied consent.
And the supervision is very important.
And when supervision, when we say, a lot of times you see that the mentor will just be standing there, he's operating there, mentor seeing the screen. Actually, it's not possible. If you're looking at a 2D screen, you cannot make out the depth. You have to see the training, or the mentor should see through the side viewing microscope. Then only the teaching becomes really effective. Or the 3D screen, if you have it, that is fantastic. Even you don't need to bend and watch it. You can look at the screen and train your fellows. I feel that is very, very crucial.
Thank you, sir.
We have the RTO system now, and it's, I think, a big boom, not only for the surgeon but even for the teaching, the distance. Really fantastic it is, and I think that's going to be the future, as TTL has sort of mentioned.
Thank you, sir. So I'd like to now invite Dr. Deepak Meghur, excellent teacher, great surgeon, great YouTuber. So, and congratulations on your award.
Thank you so much. Respected chairperson, I think I'll be speaking on the cataract surgical training aspect of it, specifically the surgical training aspect of it. And I wish there are more trainee students here as well, because this talk is going to be including both the trainers as well as the trainees. So I'll be speaking on the conversion from a novice to an expert surgeon. I think the first thing a trainer or a trainee has to imagine that, for a trainer, I think you need to imagine that when we start training, that once upon a time, the trainer also was a novice. I think if you recall that stage of your career and what difficulties we went through that, teaching a novice becomes much more easier. Over a period of time, we just tend to forget what all difficulties which we had. And it is a journey from being a novice to develop a reasonable expertise. I think remembering our studying days would definitely help a trainer. And for a novice, I would say that it's just a matter of time. Anybody can, over a period of time, can reasonably harness his surgical skills. So as we all know, surgery is skill based, and there are different stages of skill acquisition. And the psychologists have classified the skill levels into these different stages. And I think the most important part of us to understand is that it's almost impossible for us to directly jump from one without going through any of these. I think each one of us would have to go through these, and to begin with, all of us would be novice. That is one thing to understand. And what changes over a period of time is, from a novice to become an advanced beginner to proficient to being an expert. I think the most important thing would be the quality of decisions which we take when we are a novice, and as the time with reasonable expertise, the quality of decisions which we take, that is the one thing which actually is going to change over a period of time. And the best part, the beginner will always think that he is very competent, because he is totally ignorant about his incompetence. So that is where we begin with. The surgery is actually when we begin. The novice is almost unconsciously incompetent. He's not even aware of his deficiencies. And actually, the real beginning of this training process starts when he becomes conscious about his incompetence. That is where the training actually begins for any surgeon. And over a period of time, gradually we grow to become consciously competent. And over a period of time, the eventual goal is always to become, competent, and we are unconscious about competence. The most common question asked by a trainee: how long would I become? Will I take a time from becoming to become an expert, like something like say Dr. Suhas, Dr. Vidya is there? How long would it take? Well, obviously the answer would be, my answer would always then to go and look yourself in the mirror. So the how long the journey is going to become is basically depending upon the candidate or the trainee himself, the surgeon himself. So it is going to be very cliched answer that what are the things which could be like. So I'd like to just try to divide the whatever soft skills or hard skills you want to have into these 7 commandments, and I'd like to delve into each of them individually. Most importantly, I think rather than having blessed with some good surgical hand or eyesight, I think attitude is something which is going to differentiate how fast you're going to learn. So we should never forget that patient's interest and their well-being is our only goal. If this is ingrained in our training from the first day itself, it is going to ease a lot of it. There's no other business for us. We're here only for our patients, and this dictum is going to apply whether you're a beginner or an expert. It makes decision making very, very simple. During the learning curve, if you are struggling with the case, if your patient's interest is priority, rather than you trying to be adventurous, take the help of a senior surgeon. And in a private practice, always refer to a colleague. And if you are already an established practitioner, or decision making like buying an equipment, consumable, etc., if we keep a primary center that patient's interest is a primary goal, then most of the things will be sorted out very, very easily. The first thing to learn, obviously, is to have the right attitude. That is what is going to differentiate you from how quickly you're going to learn, rather than focusing on the surgical aspect of it, as I say. And second thing, for all trainees, they should learn to understand to say, wow, start to appreciate your peers or your seniors or something, rather than being cynical and just comment that there's something blessed with something else. And third would be you getting inspired. If you learn to say wow, then that's when you get inspired. It's a popular saying that inspiration is just only 1% and perspiration is 99%. But for that 99% to come and kick in, you have to have that 1% spark. If you don't have that 1% spark of getting inspired, there's no point in having your 99% perspiration. So these are some basic things, and obviously finding a mentor nowadays is extremely easy. It can be offline, it can be online, and if you are having a mentor, whether you're in person or offline, I think trying to learn the art of thinking from your mentor is far more important than learning, how to hold the surgical instruments, all those things. Get into the mind of your trainer, how is he thinking? That is the most important part, which I would like to train my trainee as a trainer, rather than the basic necessities of surgical skill. Basically, the surgery is nothing but it is a way of thinking. And the next would be you have to train your trainees to the habit of pursuing excellence. There's nothing like chalta hai attitude. The only goal you should have is to have excellent outcomes for your patients. So Rancho was right when he said you don't chase success. You just pursue excellence, and success will follow pants down. And it's very cliche. How do you pursue excellence? It's always focus, passion, dedication, and hard work. There is no shortcut for it. Absolutely no shortcut. It's a very cliched statement, but it is stood the test of time. That's how it's going to be. So if you have these goals, you're having excellence is your only criteria, then you ensure that your training is on the right side. Third most important fear a trainee has, or a myth, I would call it as a myth, that they believe from our childhood they say that a great surgeon is born with great hands. How much minute I have? Over? Okay, I'll finish with this. So a common perception is that great surgeon is blessed with great hands. I believe that it is a myth. Surgery is absolutely not done with your hands, but it is done with your mind, and it can be learned and it can be taught to every novice surgeon. So, in our local language called Hatgun or Kaiguna. So, I believe that it's all over a period of time, each one of can develop this and it can be learned and taught. So, what we basically read the surgery is done with the mind, and it is we need to train the mind of our young trainees. That is where the fallacy is or the lacuna is now. Just teach them the art of thinking, and everything else is falls in place. So training the mind is probably more important than training the surgical skill. But of course, we need to ensure that they understand that knowledge is the real power. The surgeon has become great because he, over a period of time, has assimilated enough experience, knowledge, and education. And all these have resulted in making his mind much more superior than an average surgeon. I think with these things, I would like to conclude my presentation because of paucity of time. Thank you so much for your attention.
Thank you so much, Dr. Deepak. Really brilliant presentation. I'd like to ask a question to Dr. Habibulkar sir. So you have been a great teacher, and I think a lot of students have learned just by observing you operate. Whenever you speak to your students and when you actually teach them, when they are doing the surgery, do you actually handhold them into how to exactly use their hands, or how exactly do you go about that process? For example, a simple phaco surgery.
Well, it's a good question. Yes, when I say handholding, it's truly handholding. But very often, like when you're doing a trench, I mean, now with 3D, it's a different ballgame altogether. With 2D, unless you're seeing those side scope, it's not possible to know that depth. So I tell them, like, the trench you have to do in a particular way. He'll try and understand what you do, but no, if you can't do it, you kind of hold his hand and take him through it. That you need to do a couple of times. And once he gets into that group, you know that he's doing it okay. So that means, I fully agree that the surgical hand is a myth. No, it's not. But everyone can eventually become a good surgeon. See, some may have better skills in their hand, that's for sure. Maybe they have developed it from the childhood. But someone who's not, when he comes into residency, he spend a little more time on it, I'm sure even he can be. Because the reason I'm telling you this is, there's a big difference between the Indian residents when they come there to learn, and then the foreigners when they come for a hands-on training. Now Indians we have done lots of things before we start training. Whereas a foreigner when he comes, he is zero. He has not touched the cataract. Even then in 3 weeks, what he learned is exactly the way you want. Because his mind is clean and you are teaching the way you have to do, and they just copy. That doesn't happen with some of the lessons because they have learned at different levels from different people and it's all mixed up. But then handholding is a necessity.
So, and just one last question. Many times when the student is actually operating and he has a problem, it's very easy for the coach or the mentor to say, okay, wait, I'll take over. So somewhere that kind of diffidence gets in, that whenever there is a problem, I just stop and then somebody else will take over. So somewhere their confidence gets a hit. Suppose, because especially if they go back and have a complication, then every time they are in a problematic situation, they just want to give up. How do you actually handle the student in those situations? Does a teacher actually go up and say, no, you go ahead, let's see what happens, don't worry. If you think you want to dredge a little more deeper, at that point of time, when he takes that decision on his own instead of giving up and somebody else taking over, and he says that yes, now I'm able to cross that, probably that will boost his confidence. So what is the thoughts of the panel on that?
My thoughts on that, my thoughts on that are, it all depends on what is at stake at that particular moment. Now let's say there are some surgeons who just see on the screen or the back through the binocular and just continue to guide them. But then, let's say the rexis is slightly going out, and you are kind of guiding him to do it properly. Because even if it slightly goes out, and even if it totally goes out, nothing great is understood. But then, if he's already caused a PCR, and then if he doesn't know his basic steps, like he has to stop, lower down things, and then put him in squat and dot. These are the things he should kind of rehearse before he actually sits to the screen. So obviously he's going to do it. You are only going to assist him to do it. But if you think the nucleus is about to drop, if you don't intervene, probably you will ask him, he would also know his limitation. It depends on different cases.
Dr. Rajendra, sir. Yeah, please ask. One last comment and then.
Yeah, I think one of the point which actually sir really made is it's really case dependent basis. If the case where you feel the person is capable to handle further, you can let go and see. But if you feel at any point you have to take over. See, being a training institute, we shouldn't be in a fact that okay, it's fine, it's a training institute, complications happen, chalta hai. We don't monitor. That is completely wrong. We have to, at the end of the month, you have to see how many cases of complication are happening. Then we have to monitor, audit. Why was the complication happening? I mean, was the training, it shouldn't happen. Actually, normally at the end, the outcome should be good no matter what, even if it is a training institute. So we have to really be aware and look into it, definitely.
Thank you, sir. I'd like to now invite the boss himself, Dr. Rajendra sir. And we are really very, very fortunate and lucky to have you, sir, here as the chief of Arvind Eye Hospitals, and I've had first-hand experience as to how well he teaches and the kind of inspiration he gives it to all of us. Thank you so much, sir, for being here. Looking forward to it.
Yeah, thanks for this opportunity. And it's also good to speak to all the experts and faculty members here on the training part of it. Dr. Chitra actually asked me to talk how the camp activities can be enhanced or used to enhance the quality of the training. I mean, it's really important. No? There are, as ophthalmologists, our duty is to see how do we eliminate the needless blindness, especially due to cataract. But if you look at the studies which have looked at the barriers for cataract surgery, they've seen that the poor surgical outcome and the inadequate access are the two major impediments for people to avail the surgeries, especially in a low resource settings. So then one is we need to improve the surgical capacity by adding additional surgeons and also by providing the equipment that will address these two. And again, it's also about the success of the whole thing also depends upon the surgical quality. I mean, this is where the volume really matters. Surgical volume gives the surgeons a better manual dexterity, it improves the surgical skills. Because as the volume increases, it also helps to bring down the surgical complications and resurgeries. And if it all can be done in a kind of a controlled environment, it always really helps. And here I would like to show this, this very crowded slide. You see this first part of the graph. This is the first 100 surgeries done by postgraduates. And the first graph, as you can see, is about intraoperative complications. These are about post-operative complications. These are about the resurgeries. The first 100 surgeries we have seen, it's around about 4.3, 4.5% the intraoperative complication. The next 100 surgeries drops down to 2.5. Then the third 100 surgeries drops down below 2.2. Then in the fourth surgery, the fourth 100 drops to less than 2%. By the time when they come to 600 surgeries, the incidence of the complication drops to close to 1% or less. So the volume really matters. Similarly, the post-operative complications also reduces, but we haven't seen a great impact on the resurgeries. So, and the volume also really matters, and in Aravind we are fortunate to have a large volume of patients, not only coming through the camp, but there is also a walk-in free patients. So initially, whatever the training happens, it's all the free direct walk-in patients who will be able to come for regular follow-up because they are all from the nearby areas, and in the camp surgeries, they are able to do only when the complication rates are low. And while the volume is important, a structured, scientifically based surgical training program is also equally very, very important, which will include the wet lab training, because the fellows start there, especially in the care. It's all talking about the fellows. The surgical training starts in the third month. Usually, they start off with their wet lab training, followed by intense surgical training under supervision. So and in the wet lab, we spend enough time. We have the simulators, and we have the bow ties, and we also have ways how we can bring the hand-eye coordination. All this is done to minimize the complications. And typically, they start with small incision surgery, the third or fourth month of fellowship. They start with step surgeries. When we talk about step surgeries, we talk about what they do on first day. Normally, start with connective flap section and even maybe suturing. And the second and third day, they do those first two steps and do the capsulotomy. And the fourth day, they do this. When they do only minimum steps, probably they do it not only one patient, maybe 3 or 4 patients. So by the time they come to the last day of the training or the 7 days, they probably operate on one patient. And they are able to independently do all the steps in 2 weeks. And all the surgeries are done under supervision. And here the only difference is the whole thing is packed. All the training is done with the 1 month. Every day these people get to go to the theatre. Every day of the month they go to the theatre. And that helps really to improve their minimize their complication rate, build up the confidence so that they can be trained further with minimal supervision. During this period, we also have a dedicated trainer, usually a first year consultant or a senior fellow. They spend that 1 month with the fellow for the whole of the initial training. These people stay with this particular person from both the morning to evening. So as this constant interaction also really helps in the trainings. And we also not only teach them but also evaluate all the post-operative. So, and we also have a way of monitoring, having a log book and a daily meeting with the post coordinator and also video recording of the cases, usually the 3rd week and again in the 8th. And we also use this ICO's ophthalmology surgical competence assessment rubrics, we call it SASCR, and for at least for the first 25 to 30 cases to see before the by this time they are usually independent and do all of them. And these staff, they also attend the weekly complication audit meetings for them to really understand at what step it happens and how it was managed and what was the visual outcome at the time of discharge. So all these details are all discussed. The person who had made the complication and who managed all will be there, and this is a great learning for them. And coming back to the camp really brings a state that really helps in the training. As I said earlier, it improves everything. But involving them not just in surgery, but in the actual outreach work, as it was mentioned earlier talk also, they really understand the access challenges of the underserved populations. And this understanding also will probably help them to do this take up this work later on. And they keep doing the campsite without any equipment, assessing the patient, trying to choose the patient based on visual criteria and the type of cataract and the need for avoiding complex cases because these patients need regular follow-up to be referred to the hospital. And also evaluating the existing systemic diseases. Today we see about 40 to 50% of all the patients who even come to the camp have diabetes or hypertension, and how do we manage these patients also becomes important. Again, these training these patients in the base hospital, they've seen it in the base camp. They also do the screening with the equipments in the hospital, really helps them to understand the whole thing better. And again, as the initial training part really helps them to minimize the complications. Where the 1 month when they are able to minimize the complication. We also facilitate operating on 2 tables so that they be able to do volumes. Usually these fellows after about 18 months they will be able to do at least 25 to 30 seconds. And again, there is talked about complication management. We have a structured 2-day training program for these people as they finish the 1 month of their training program. They have 2 days of kind of a seminar, in-house seminar, for them to understand how to do the surgical management. They are taught how to do the anti-protective in a much possible. And what is also really makes them a good surgeon is when they start playing the role of a trainer. So when they are the senior fellows, they have done at least about 20-21 months of fellowship. They spend at least 1 month as a trainer for postgraduates. It really helps them to understand the whole surgical steps and taking lectures further their knowledge, and that here they also have an opportunity to manage the complication of the trainings. So all of that that completes the whole cycle. And we also have a system wherein we capture all the information about the surgery and complications. We also do a benchmarking. And that is available for these people to look at on any time, any day. They'll be able to look at their data with others' data. And as you can see, nearly about 60% of the surgeries are done by the medical officers for the small incision, which is mainly the patient who come from the camp and the free hospital. But nearly 25% of the volume is done by about 60 to 70 fellows, averaging about 400 to 500 surgeries. And here I'm just showing the data of the people. These are the actual real data for the people who are there now. If you see from the row from 11 to 15, they are the people who are in the first 6 months. There you can see the complication rates of 7%, 3%, 5%. But then as they cross that period, then it comes down to about 2 to 3%. And once they cross the threshold of about 900 surgeries, you can see that it comes to about 1%. But there is in between even the complications are less, where they don't operate complex cases. As the volume increases, they also start doing complex surgeries, again the complication rate increases. Just to conclude, with this kind of a scientifically structured training program, if it is supplemented with the volume, you'll be able to develop a confident surgeon. And they are all aware of the role and usefulness of the paramedical staff, the community work. And we also talk about practice management. They understand the social marketing part of it. And when they go for the camp, they also lead that team. And when they are a trainer, they also lead that training team. So all that develops their leadership capacity as well. And the whole key lies in an adequate pre-surgical training, which is for the wet lab, learning in a step pattern, and the close faculty supervision. All of that will really help in shaping these surgeons who will go out and hopefully able to take care of the blindness and help in achieving the goal of eliminating needless blindness. Thank you.
Incredible presentation, sir, as always. One question to you and Dr. Vijaya ma'am also. Ma'am, in all these years, have you ever come across an incident where you had to change your program? For example, in cataract surgical training, for the trainees. Did you need to make any change in the training program?
Yeah, we always.
Or in all these years, surgical techniques have evolved. So, or has it been the same over the last 5 years?
Constantly the changes has to be there. For example, recently we have a simulator, the health simulator, that really helps now. In addition to the regular training, wet lab training, we also need to put them on 10 days of training on simulator. That really helps. Because there is also feedback mechanism that helps them to understand the whole process. Then as they make this decision badly, what kind of complications they get, there's a feedback that comes from the patients. All that really
A very good presentation, and to your question, maybe I want to make a small comment about this presentation. Yes, we have changed over a period of time. Wet lab has come in, simulators have come in, and initially there is a lot of emphasis was given to the ECCIOS, then SCCS, then the paper education. Now, most of the time they start up with the SCCS and then move on to the paper education. But in our setup, we still give importance to some ECCIOS because we want them to be well versed with the switching techniques, and also we insist on practicing the switching skills in the wet lab. And coming to a quick comment, and it's great to see the volumes the every student gets, and it's not possible for every student to go through that kind of experience to become good surgeons. So what I strongly believe in is, like Subhas has said, that you create a pattern. This is the way it has to be done. Step 1, 2, 3, 4, 5, 6, 7. Don't deviate from it. And be there with the student all the time till they do those steps properly. And it is really holding the hands doing it. And even with this, when you do that, even with the 25 to 30, you will see a well-trained surgeon coming out. I think ultimately it boils down to your needs, what you have, what you can offer, and how you can make it
Yes. Thank you so much, ma'am. I think we'd like to now invite Dr. Ronnie for his presentation. Thank you so much, Ravinjan sir. And it's really incredible to know the kind of thought process that goes into all these training programs, and people are really lucky. Today's students are really lucky to be learning under your guidance.
Volume does matter, as Abhi rightly said. The more the volume, the better for the surgeon. They can become better. But I also agree with Vijay, because having come from Canadian, to do 100 surgeries with all the protocols in place, what she had mentioned, you can be very good at it. Yeah, under good supervision, following all the parameters, recording each case, and having a look at each of your recordings in the evening when you go back. So I think all these matters.
So we'd like to now invite Dr. Ronnie George, sir. He's a senior consultant in Chennai. Director.
He's a great person.
Yeah.
Person is sitting right there. So good morning and thank you for the invitation. So I just like to again reiterate what everybody has said. I was fortunate to train under many different people that I've had Ravi Thomas hold my hand and teach me how to suture. So that definitely somebody sitting next to you for 2 hours and helping you to do surgery makes a huge difference compared to somebody going it from somewhere else and doing something else. So when you look at Oscar, so when you look at the Oscar assessment for trabeclectomy, these are the whole bunch of steps that you need to go through there. When you look at some of these, there are many of these that you actually learn during cataract surgery. So when you're looking at a combined cataract and glaucoma program, you don't really need to focus on these. So you need to focus somewhat on these things, and a little bit like the conjunctival incision, superior rectus, and the peripheral areolectomy. You can work into your cataract training program itself so that they get an idea of how to do it. So, just like Dr. Vijay said, the first step we do for everybody, even our glaucoma fellows who come, is to assess how good they are at cataract surgery. And this is a big challenge for us because now there are many programs which don't let you do any extra camps. So you have somebody who's finished 3 years of training and has done a few trauma surgeries where they put a few corneal sutures and they've not done any other suture. And suturing is required for glaucoma surgery, for corneal surgery, for vitreoretinal surgery. So that's a big challenge that we are facing now. And of course, then we assist them how they are SSCS and FACO, and generally when they are doing their combined surgery, this is the pattern that we will do. We will teach them how to do combined surgery extra care. And with FACO, we have sort of, we don't really encourage them to do too many SSCS trabeclectomies because there's a lot of skill work being made at that time. So that's so just like Dr. Vijay said, we encourage rigorous practice on sponges, etc. on the day before they operate. In fact, one of my colleagues insists that they send a WhatsApp video of them actually doing the process the day before because it improves their suturing skills the next day quite significantly. So we do a parallel approach in the sense we start the wet lab and at the same time we start with the steps of surgery. And the steps that we follow for trabeclectomy are the first 2 steps we will get would be a interval therapy, the phytobacter application, and then a flap creation. Then they go to creation of the ostium and PI, then flap closure, and only finally conjunctival closure because that's one which is most critical in terms of tissue handling and in terms of their suturing skills. So the first 2 they get initially and the bottom 3 later. So it would be nice if we had something like this, but it costs about 18,000 rupees to get one good modern eye to do a trabeclectomy suture. So what we do is use board size, and we have a 2 or 3 wet lab settings like this. And 2 things that we encourage is one that student either has somebody peeping in on the side when they initially operate, or we encourage them to take a video of what they are doing. The adapter there, they can put their cell phone and take a video, and they can go back and see what they are doing wrong or show it to us. When it comes to wet lab, there are 2 things that we teach them, and one is a paracentesis creation, which is a little difficult to do on both sides because of the softness. And I put these videos there only to show you that the tissue handling is not quite what you see in a human eye. It's much softer, it's much spongier. So it's not quite the same as doing what you're doing, but they get a handle on how to do some of the steps. So here again, you're doing the ostium creation, and they learn how to suture the flap, and typically in one eye they can go around and do maybe 6 to 7 procedures at one time. We teach them how to do releasable sutures also in both sides, and then they can come back and do it in bonus. The challenge, of course, is conjunctival closure. While there is a model available for this, this is again about 30,000 rupees. So conjunctival closure, we really don't have any good model, animal model in which you can practice this. And this is the biggest issues that we have with glaucoma surgery. We also train them in the steps of glaucoma implants, and they learn how to. Typically, this would happen the same way. We have a few teaching valves, so they can learn how to prime the tube, they can learn how to place the tube, and again, it's not the same as doing it with the eye because these eyes are a little softer, and you will see that when they're placing the tube, it becomes a little difficult. Placing a plate is surprisingly easy because you can use the finger and never hand posteriorly, so they get a feel for pushing it in. But it's much easier to do it in this than in a human eye because of the orbit. So tube placement here again, because of the softness of the globe, it becomes a little difficult. And but here with one device, teaching device, you can teach 8 or 10 students. It's not a problem. Priming stays okay as long as they don't repeatedly cut the tube. You don't have a problem in doing that. And they do the same thing with us in theatre also. They learn how to prime. They learn how to place the tube. You do have training models like this, but again, very expensive. So a stepwise approach for tube training is in parallel to wet lab practice. They learn how to do one interaction sutures and conjunctival peritoneally with us. They learn how to prime the valve, and once they finish, they're comfortable with that. Then they look at giving them steps of the rest of the procedure. Post-op assessment, I think, is something that is not covered enough in glaucoma training program because that is really, really important. They're asked to see all the glaucoma post-ops that we operate, and they're asked to assess and make a plan as to what their patient needs. And for their own post-ops, the way they do it is they assess, they tell us a plan, show it to us, and we confirm what they need to do. So this happens for every single patient that they operate and every single post-operative visit that they come, so that by the time they leave, they know what they can manage. In terms of managing their post-op complications, they are allowed to do their injection file refuse, the releasable release, the Artemis suture lysis. We encourage them to do their own needlings under supervision. If they have a necklace misdirection, we teach them how to do a gag anterior button, and we teach them how to do an AC reformation. Anything beyond that, in terms of conjunctival buttonhole management, choroidal drainage, eyebrows on the eyelid drainage, flat plate surgery, and conjunctival spinal vascular, they only learn to observe because at this point in time, we don't think they are mature enough to benefit on the go. In terms of lasers, laser iridotomy, hyalodotomy, suture lysis, SLTs, Aiocs, and micropulsators, they are actively encouraged to do. The SLTs especially, we encourage them more and more to do because it gives them a better handle on bonioscopic anatomy. So what next? And I think from SLT today, everybody's talking about the micro-invasive glaucoma surgery. So I looked at how much MIGS residency programs in the US give, and it's not much. So what you see is the middle number for MIGS is pretty small. It's about 2. So 50% of residency programs in glaucoma give 2 MIGS or less. Compare that with 2 trabeculectomies, 2 expressions, and 5 tuitions. So it's not a huge amount of data even there, but this is going to be a challenge for us coming forward with more and more MIGS coming to a picture. So basically you look at these MIGS sites, and there is really currently no animal substitute for this. If you need to train them in MIGS, you will have to do it with this. And what we do try to teach them is, we give them good bonioscopy skills, we teach them how to do direct bonioscopy so that they are familiar with surgical bonioscopy, and we conduct a hands-on workshop using those type of models at least once during their program so that they've had some exposure to that. The challenge with mixed training is, of course, you cannot give them devices because of the cost and efficacy considerations, and the same challenges occur for implants too. Going forward, this is the other challenge. Trabeculectomy rates are decreasing because we have more and more medications, and across all surgical programs in the world, the number of trabeculectomies postgraduates are getting a standalone outcome less. The number of combined surgeries has gone up a little bit. Implants are expensive, which are even more expensive. So what we can try and do is we can give them the skill set to graduate to more complex procedures, and I think that is one thing that we have to focus on our programs on. Thank you.
Well, request Tamil to get ready for the talk. A few questions for the expert panel. Like Arya sir had mentioned that with chronic experience, the complication rate comes down to around 1.3% or so. So is there something in trabeculectomy like that, any acceptable rate of complication? Yes, for the residents after they have done so many trabeculectomy.
I don't
Because
think
even published literature says it's around 25% for very
see, unlike cataract surgery, which is very, very predictable, when if you teach this way, you can get a predictable outcome. Whereas trabeculectomy is not predictable even in an experienced person, depending upon the clinical case and so many other things. So, our aim in teaching a good trabeculectomy is give them the good surgical skills as well as how to do a good trabeculectomy in a stepwise manner, like what Ronnie has said, and they have to learn how to manage the post-operative complication from the knowledge they acquired during the fellowship. Because even among our hands, a post-operative response varies very widely because it is a very unpredictable procedure, unfortunately so. And so this we don't have that kind of information to provide. In contrast to this, a tube has a little more predictability as far as the complications are concerned.
Would you recommend giving residents exposure to pediatric glaucoma surgeries during that?
I mean, they do observe and maybe few steps they do, but not in a full. And we encourage them to do a good thorough evaluation of a pediatric ophthalmologist, how we should. And we have a set protocol that includes the total evaluation of the child, that including the pachymetry and axial length, gonioscopy, how to measure the preference under sedation, and how to do the gonioscopy. So that it gives the skills to do the direct gonioscopy. And if at all, we allow them to do few steps, not in a temple.
Request Dr. Tamil, Senior Consultant, Cataract Surgery Information, to present her talk on maintaining a logbook, the purpose and need.
Good morning, one and all. I'll be talking about maintaining a logbook. The quality of clinical training depends upon two main factors. One is the number of cases the trainee is getting, and second, the clinical expertise of a trainer. And we know that there is a new standard set guidelines about the number of cases a resident will operate, and also the teaching experience of the trainer varies. So there is a great variation in the learning experience of a resident. So logbooks have been introduced to ensure consistent quality and standards in surgical training. I'll be sharing my experience how I introduced the logbook for training at the Eye Foundation. What are they? They are nothing but a set of learning objectives for a specified education time period. So once the resident comes to know about this, they will know what is expected from them. So this imparts a right positive attitude and better engages them in the learning process. Overall, it improves the structure of the training. Though logbooks are perceived useful, few of them, like here as shown the student response, around 20 to 29% perceive them as not useful. When it can flop, if the structure of the logbook is not clear, and when the work becomes more of a data entry, it becomes boring and less engaging. So with constant monitoring and structuring the logbook clearly, it can be made really useful. So this was the existing logbook which was there for our DNB residents. Here, they enter the individual patient details about the operative notes, the complications, and the post-op visual acuity. Overall, it looks good, but what are the downsides? Here, there is a repetitive writing of the same surgical notes again and again, and unless it is not, it is monitored, we are going to fill only during the exam completion. And so it becomes a boring and less engaging. Though it provides details of the complication and visual outcome for individual cases, it does not provide any platform to analyze the visual outcomes, and hence I am not able to measure the performance of a resident. So I structured a logbook which was made very simple to help in the training process. So the contents of the logbook should be constructively aligned with the curriculum. What I mean is the learning objectives of the logbook should be integrated to the curriculum what we have. Once this happens, the students take their own responsibility of their learning process. So when I structured, I kept it very clear to mirror the activities, whatever it is happening in the wet lab and inside the OR. So at the beginning, I will introduce the logbook and understand the resident, the usefulness of it and how to enter it. And also encourage them to submit it weekly so that I'm going to give a feedback. All this helps. When I see this logbook, I know how is their learning progress, and also it gives the overview of the requirements of the clinical training. So to tell that it should be a basic, it should be simple, and also it has to be comprehensive. So our curriculum of surgical training, it starts with small incision cataract surgery at the 4th month. Once the resident picks up the comprehensive eye examination skill, and in final year we teach them phacoemulsification. So in the beginning of their wet lab, they attend a series of lectures and write modules, which ranges from simple pre-op evaluation to the Aioc calculation, and they document it. And they spend a considerable amount of time in the wet lab, 2 to 4 hours in a week. All these things are supervised. Where they learn, this is the same thing which has been they are practicing in both. So it was just to show how they are practicing their skill in tunnel and suturing technique in a both side. So here they learn to orient the use of the surgical instruments, operating microscope, and they learn the hand-eye coordination. And also for phacoemulsification, they learn to perform the nucleotomy technique in the practice eye model. Also, we take the nucleus extracted from small incision cataract surgery, freeze it, and also place it to better understanding chopping technique. All these things are monitored and supervised by the senior residents, and I also give them timely feedback. And to ensure this, I also tell them even after they enter the OR, if they want to refine a specific surgical skill, they should never hesitate to go back to the wet lab and learn the same. All this exercise tells them that they have to spend a considerable amount of time and effort in the wet lab before entering the OR, and also ensures the fact that the patient and their outcomes always comes before their training. After 4 to 6 weeks of the commencement of the wet lab training, I sit with them one-to-one and ask them regarding the various steps of cataract surgery. This includes both for SICS and phacoemulsification. So by this end of this, I will be able to know whether they have understood the various surgical steps and what are the weakness and the areas they need to improve. I leave a gap of 4 weeks and reassess them and ensure that they understand the basics of all the surgical steps. All these acts as an evidence that we have taught them that the evidence learning has taken place, and when a resident starts his or first case depends upon the surgical aptitude of the resident. I may construct judgment regarding the surgeon's training. Once they enter the OR, they enter all these things, which is the stepwise analysis of the cases, visual outcome monitoring, the complication rate, and also about the surgical audit. So this is a stepwise analysis of the case. So for each of the steps, they enter whether the step is done by them or with help or done by a senior. So once they do at least some 30 to 40 cases, this helps them to analyze their learning curve. Previously, they were not able to do, and now they are able to do all these steps by the end of 30 to 40 cases. So they are comparing themselves to themselves and not with their peers, and this triggers them to learn better. They also bookmark in the EMR that whenever the patient comes for the post-op follow-up, they will be called and they see the post-op and they document the post-op visual outcome. By this, they understand the surgically induced astigmatism and the amount of trauma the surgery has induced, and also learn about the error in biometry. Regarding complication, whenever complication happens, I discuss with them what is the best part of the surgery and what could be done better. And I always try to keep the feedback as constructive as possible. And I encourage all my residents to record and review the video. For each of the steps, they will know what is the best part of the surgery and what are the areas that need to be improved. And I also encourage them to assess the time taken for each of the steps. And for example, if a resident tells me immediately after surgery that they attempted a hydroprolapse but the nucleus didn't prolapse, When I ask why, they won't be able to tell me the reason. But when I sit and discuss with them, they will understand. First, they should look into the size of the rexus if the nucleus is not prolapsing. And second, the placement of the cannula and the technique of injection, whether it is correct or not. So once we do the surgical audit, it will help them to analyze the concept and encourage them to think critically and act according to the situation. So all this exercise which has been discussed till now, that is seeing the patient post-op, entering the visual outcome and doing the surgical audit, all these things they need to carry it over into the future professional career. So getting this habit early is really good. So as a trainer, we know that the learning curve of cataract surgery is really steep and we need to provide the space and time to give them a constructive feedback so that they can become a surgeon of highest type. So to conclude, the logbook should be constructively aligned with the curriculum and this helps in surgical training really. Thank you.
Thank you. Along with the logbooks, do you encourage recording and do you work with them on that?
Yeah, surgical video recording I encourage, ask them to review it personally themselves and along with the seniors, and if they have any doubts, they will bring it to me also. And if they have a complication, I do sit with them and watch it.
Is it routinely recorded and taken out occasionally or
routinely it is recorded, but there are two operating tables in an OR. Usually the recording system is there on the first table. So sometimes it may not have sometimes.
Yeah, because as you mentioned, you can go back and discuss. It would probably be more advantageous to discuss the areas where they were finding it a bit of a challenge to go back and discuss. That would be very good. And at our place, we also have these presentations of these recordings. Just randomly, just one recording is lifted out by the senior resident or the supervisor, and they are discussed in the entire unit or entire group of residents of that particular group. So presented and discussed. So again, it's not judgmental discussions. It's like everybody is getting an opportunity. So, and they're done with their senior residents or their supervisor faculty, junior faculty, so that they don't feel kind of threatened or something like that. But yeah, as you mentioned, it's important to discuss where the challenge occurred during the course of the surgery, and everybody can learn from others' mistakes also. So it is, but wonderful, excellently shown how to document, because now it's becoming increasingly important for them when they go onwards to have a proper documentation of what we have assisted, what we have personally done. So, thank you.
Beautiful talk, Dr. Rasi, as usual. But just three important things are very, very vital, I would say. You mentioned logbook is a must. Number one. Number two, all the cases, the resident cases are recorded and they have to be reviewed. Recorded and reviewed. Not only recording, they put it in the dustbin. So it's recorded and reviewed. Third is the surgical auditing. That also you mentioned beautifully. So these are three things I think very, very important for the surgical training program.
Thank you, Rahman. And I think we'll go on to the final talk on enhancing skill sets in publication by Dr. Chaitra Jaydev, who probably has the largest experience in reviewing and seeing and helping people and getting their papers published. So I'm sure she'll give us a lot of understanding of how we can encourage our residents to get involved in research as well as publications. Dr. Chaitra.
Thanks, Rohit. I think a culmination of all the training that each one of the speakers spoke before and the logbook, which will actually help us collate the data, and a good ending to all of that is if it can come on a paper as a publication, because it adds not only to the CV but to the growing literature that we have for our particular specialty. So I teach my residents the 7 commandments, just to make it very, very simple to them, so that it's not an overload of what is required, but just the basic principles as to why you should publish. Because leading in academics does not only mean publications, it also means being a good student, a good teacher, a good orator, and a good clinician. So, putting all that together, it helps in following these simple 7 commandments, as I call it. So I always tell them begin with an end in mind. Most of them are so confused. What am I going to do with this? Am I going to send it as an original article? Am I going to present it in a conference? So I think if you have a focus point, this is where I'm going to submit it to, or this is where I'm going to present it, it becomes all the more easier to work towards that goal. Otherwise, they're very lost in that meandering path. Next would be, do not let the type of your practice be a deterrent. Most of them are very worried that, if I go into a private practice, will I actually be able to collect the data that comes from a very, large institute like currently, they're all either residents at Narayana Nethralaya or they're fellows. So they're a little worried that once they step out, will they actually be able to collate all this data and publish it? I don't think it's difficult at all, because we know several individual practitioners who have really made their mark despite not having access to fancy gadgets or equipment. They've just been very methodical in the way they have collected data and put it together. Also, in the private practice, I think it's all the more important because you do get visibility and referrals. I have patients, who read you up on PubMed. You will be surprised to know they look you up on a YouTube or a social media of your institute and come and say, I saw your video on floaters. Now I have floaters, kindly tell me what it is. So it does not really mean that if you publish in PubMed, the patients are not going to be influenced by it, they do. And for people who are not in a private practice, who are in an institute or in a government setup, it does help in promotion. So I think these are certain things that we do need to pay attention to. Third thing that I tell them is to learn to observe, document, and record. Most often during a busy practice, we see something so interesting, and by the time at the end of the day, you can't even find that medical record number to retrieve the images or the data. So a simple thing that I have done for myself, and it's probably helpful, is to make a WhatsApp group with yourself. And now with the latest update, you actually can text yourself. So you just text that MRD number, and later on, at the end of the week or so, you can go back and retrieve all the images that you need, and you won't have forgotten. Just one keyword, like you saw, atypical coloboma, just put atypical coloboma and the MRD number. You can just text it to yourself. I mean, even if it's residents or for ourselves, it's very, very helpful. If you see Don Gas, if you go back and see, every time he saw an entity, he just described it to the best possible way and recorded it in flashcards at that time. They didn't even have access to a smartphone. And then when he found a cohort of similar looking things, he published it with a sign, and that's how we got it. Whether it was APNPP or mutes, it was all what Don Gas did at that time by collecting it all together. If you look at it closer home also, Professor Gupta, he spoke about fungal endophthalmitis occurring in 48 hours, everybody laughed. They said, fungal endophthalmitis is a chronic thing, but it cannot present that soon. But then he went on to show, and same with PCR as well. He's pioneered it just by observing and documenting whatever he found. And then you do need to take advantages of the resources that are now available to us, which was never there, several decades ago. You have academy giving out, you have closer home, Aioc has online resources, Aioc has a lot of resources. Now it's at the, in your hand in a mobile phone with both the Android and the iOS app. So Aioc is accessible on your phone any time of the day. So with these advantages, you can really want to publish more in a much faster and an easier way. And the next thing is you should be ready to publish only what you believe in. Just because somebody said that this is not true, or somebody says that this is true, it may not always be. At the end of the day, it's the editor, the reviewers, and the readers who are going to take a call on that, whether you've done it or not. That's why you have a lot of letters to the editor, sent out, because some of the readers may not really agree with you. So if you're absolutely sure in what you're publishing, then you will be able to justify or take a stand on that particular topic. Make your work relevant. Just because I mentioned that you need it for your practice, popularity or your promotions, I don't think that's a good idea. You should do it because it's going to have an impact not only on your patients but on your specialty, on the ophthalmic community. It could be a new complication that you want people to be aware of, or a new technique that you want to popularize that will improve surgical successes. So make it relevant so that people actually benefit from it. And take the road less traveled. You don't have to do what everyone else is doing. You can actually start off a journal on your own. We did that. In fact, the Maharashtra journal was started by Dr. Nayak and it's doing extremely well. And you should specialize in lesser known areas. When you do, it could be just practice patterns. Of, like, for example, somebody is very good at NABH. You may want to publish on, how to get that done easier or faster. And you can even go to medical legal issues. So if you are the authority on that, obviously you're going to be quoted and it will be very relevant to the specialty. So coming to the indices, I think most of us just know about PubMed, but these are some of the indices, the H-index and the I-10 index. These are the two most highly published ophthalmic authors that we have. The one on the left, if you see the indices, is for Dr. Amol Gupta, Professor Amol Gupta, and the one on the left is Dr. Namrata. So they both have some of the highest citations. Look at the H-index, it's 61 and 55. And this is of our current editor, Dr. Santosh Manavar. Here again, his H-index is almost 60. So that's an extremely high number. So if you have to look at just by example, what I want to show by these next couple of slides is that you don't have to restrict yourself to any one particular genre of publishing your papers. It could be a simple case report like he's done here, or a case series, a commentary, or a comment. You can have new technique investigations. We're also keyed into only case reports, review articles, and original articles. You have so many more that you can explore. You may be the first one describing a technique, you can publish that. Original research, of course, we are all aware of. The review articles, systematic reviews, these mostly are invited articles. Usually experts in the field are called to write this. Then clinical trials, a lot of us are part of. And then you have the RCTs. And then, of course, the editorial, again, written by the editor or as a guest or invited editor. So, tough times never last, but tough people do. So, we just have to toughen up and start publishing. The first one will give you that high, then keep pushing you for more. Thank you.
Thank you, Dr. Wonderfully presented. The key aspect that two things, all of us can be a part of research, irrespective of where and what we do. And secondly, if you do any research, if you come across anything, I think it is your moral duty to publish. The one reason is, of course, it is self-gratification and it's good. The other thing is it's a way of learning. So if you are teaching it to somebody, you actually realize you learn so much more about it. And the third thing I feel is that maybe this is not the greatest path-breaking discovery that you've made, but it may lead on to greater things. So a lot of research leads on to bigger and bigger ideas. So that's why I said that, you come across something which you find is interesting, and if you write it in a reasonably interesting way, I'm sure it can be published. And as I said, it can go on to kind of stimulate research, which would be amazing. And thank you, Dr. Chesa, for a wonderful talk and extremely stimulating and invigorating and essential.
Chaitra, wonderful as usual. But I feel that the first 10 or 15 publication is always starting trouble. Once you do that, overcome that barrier. But if you have to overcome that barrier, you need to have the mental resilience to do it. So how do you overcome that? How do you tell your residents or postgraduates to do that?
So I think the most important thing is the first rejection. I think that hurts so much that you really need to recover from it and go forward. But then, sir, the opportunities are so many. It's not just one journey. You can just or try it another 5-6 times. It's just that little bit of persistence and perseverance. I think then, like you said, it's the first 10-15 journals, and then you become a pro. Okay, it's come back from rejection, thoda bahut keywords change kare, let's change the format and resend it. I think the one paper of mine which took the longest time to publish was about 14 rejections. And the 15th time it got accepted. So it's there, it's done. I think it was neovascular glaucoma after YAC capsule. Somehow it just never went through, but then finally we managed to publish.
Very interesting topic.
Yes, just after YAC caps, the patient developed NVG. Thank you, sir.
Thank you very much. There are no more comments. So I think we'll move on to, if it was on time, we'll move on to the next session.